Uh, Thank you, Dr. Ashish, for the opportunity. Thank you, Chairman Sir. Extensor apparatus injury after TK is very rare complication, but it is a very serious complication. It has got significant effect over overall functional result. You need to identify that and you need to treat them accordingly. This is one of our patient. We did bilateral TK roughly 5 years ago. But on day 2, when she was being mobilized, accidentally she fell down and sustained bilateral ligamentum patelli avulsion. We did repair with the help of semitendinosus and augmented with SS wear. With that, patient was doing well for subsequent 2 years, but she fell down again. This time she sustained bilateral periprosthetic fracture. On the left side, it was relatively stable. We treated conservatively. But on the right side, we had to do distal femoral replacing type of prosthesis. With this, she is now being mobilized with the help of some walker and doing well. So with this extensor apparatus injury is a very devastating complication. It has got significant effect on overall patient mobility and outcome. Patient will present with extension lag, instability, pain, and diminished movement of the joint. Injury can occur either through the quadriceps tendon or through the patella, or most commonly patellar tendon avulsion from the tibial tuberosity. What are the risk factors for this injury? If you are operating in a knee for multiple times, particularly in presence of stiffness, when you are trying to evert the patella, that may lead to ligamentum patelli avulsion. There are some comorbidities like diabetes mellitus, rheumatoid arthritis, chronic renal disease. Those who are taking steroid for long duration, they are prone for this injury. What are the risk factors related to knee replacement? If you place the implant wrongly, if there is excessive internal rotation of the femoral or tibial component, that would lead to relatively lateral position of the tibial tuberosity, and that will increase instability and subsequent fall. If you do extensive lateral release when you are doing TKR through the medial parapatellar approach, that may lead to injury to the superior and inferior lateral genicular vessels and will lead to avascular necrosis of patella that would increase risk of patellar fracture. So try to place the implant in proper placement, avoid any internal rotation. When you are evaluating a patient with extensor apparatus injury, you need to look for whether there is any malalignment or instability, whether there is any active ongoing infection or not, whether the patient is a candidate for revision surgery or not. If the patient presents acutely, then you have to repair it, and at the end you need to augment it with the help of some autograft. In case of chronic presentation, you need to reconstruct it. For reconstruction, you have option of autograft, allograft, sometimes a synthetic material like Marlex mesh. Quadriceps tendon rupture usually occurs when patient is trying to getting up from low chair. These are usually trivial injury. In this patient, there was quadriceps avulsion. We did USG that confirmed the diagnosis and had to do repair with the help of suture anchor. Patellar fracture nowadays is rare because we have almost stopped doing patellar replacement. But if the patient presents with patellar fracture, you need to evaluate whether the fracture is stable or not, whether there is any extensor apparatus injury or not. If the fracture is stable and extensor apparatus is not injured, try for conservative treatment, avoid operative intervention because there is a very high risk of complication if you do surgery in this patient. If the patient presents with displaced fracture, if the bone stock is good and implant is stable, you need to do fixation with the help of tension band wiring. On the other hand, if the implant is loose, particularly patellar component, then if the patient is asymptomatic, you can go for conservative treatment. But if the patient is symptomatic, then you may have to remove the implant, or if the patient is having good bone stock, you can do revision patellar component replacement. This patient, 70-year-old female, underwent TKR 10 years ago. She fell down and sustained a transverse fracture of patella. We did tension band wiring and it was sufficient for her. Third common type of injury is the patellar tendon rupture. This is because of compromised blood supply, particularly when you are doing revision cases. In these cases, you need to repair it and you have to augment it with autograft. This is one of our patient, a 73-year-old female. She fell down, sustained periprosthetic fracture. We did internal fixation. With this, she was doing well, but she fell down again. This time she sustained lower pole avulsion. We repaired it with the help of suture anchor and augmented it with semitendinosus autograft. This was overall repair. This is postoperative X-ray. Now patient is painless, mobile, and there is no extension lag. In chronic cases, you need to reconstruct it. If autograft is not sufficient, then you have to arrange for allograft. If you can use Achilles tendon allograft, or if there is more severe injury, you can go for whole length extension mechanism allograft. Marlex mesh, I do not have any practical experience with this because it's not available here. So in conclusion, you have to prevent it. It is a devastating complication. If the patient is asymptomatic, relatively stable, try for conservative treatment. If the patient presents acutely, repair it, and you need to augment it with autograft. In chronic cases, you can do reconstruction with the help of autograft, allograft, or Marlex mesh if they are available. Thank you.
Thank you. Any questions? No. Thank you very much. We all thank all the speakers for such a nice presentation and very burning subjects like